Because we just transitioned so
we
quickly.
transitioned so quickly. Yeah.
I don't
We're
know.
good. We're live. We're running. We're Instagram, YouTube, Facebook.
All of those except Instagram. Instagram's always lagging, but
yeah.
Outside of Instagram, you're technically live.
All right. Hello, everybody. Welcome to Fertility Factor Fiction. I am your host, Dr. Rahi Victory, a double board certified reproductive endocrinology and infertility specialist. And off to my side here and kind of across from me is Tariq Ibrahim, the doctor of all things social media.
Hello, everybody.
You forgot your scrubs tonight.
I did forget my scrubs tonight.
Oh, disappointing.
It was disappointing, to be honest.
Yeah.
It's because of the story I had with the.
We need to get some probably figs and then big letters write FFOF on it because
we got to brand it up.
We got
to merch it up.
We need we actually need a logo and all that stuff. We should do that.
We should do the whole show as its own entity.
If anybody watching the show is a graphic designer and wants to throw out some ideas for a logo for Fertility Factor Fiction, we might adopt that. Yeah.
We'll definitely consider it.
We would definitely consider it. Yeah. Send us some stuff. We'll absolutely consider it. So, welcome to the show tonight. We don't have a specific topic this evening because there wasn't any really great research or studies out, but I wanted to open it up to questions and let you all have an opportunity. I will.
Well, after what happened yesterday.
Yeah, day before yesterday.
Yeah, day before yesterday for questions. It seems like there's a couple out with them. There's a couple out there.
So I was on call and it was a psychotically busy day, but I didn't know that when I first started the day. So I sat down for 10 minutes and I thought, I got 10 minutes. Let me just put out one of these posts. I hadn't done it for years. And I thought, okay, this is going to be cool because I can kind of say, hey, if you have some questions, I'll just pop up some quick.
You know what happened? Right? You forgot you're popular. You forgot you're a thing.
So when we used to do this at the start, I get 10 questions.
Yeah, that's right.
And then it kind of was 15 or 20. And honestly, I don't think we'd done it for 4 or 5 years, right? It was a long time. We haven't done it
for a while.
It was a long time.
Yeah. I thought because the questions became so cluttered on here.
Yeah.
There was no need to preempt it.
And I have to say, full disclosure, right? I kind of stole that idea from Rahi, who was doing it quite a bit, and we're friends. And I thought, this is a good idea. And she told me she does it. She told me to try it. So I was like, yeah, this is cool. I'll do this. But then I dropped it because I didn't think it was doing that much. And then I was just bored and I thought this would be kind of fun. And my own daughter asked 3 of the questions. and then I went crazy. I think we still have 50 something questions to answer. I don't even know when I'm going to have time. It's completely bonkers. So yeah, it was a great night. I did a bunch of the questions for a brief period of time. I think it was around 8 o'clock or 9 o'clock at night. And then I kept delivering baby after baby. I delivered 13 that night. And then I got to the very end of everything that I thought. We were only a couple of quiet women on the board, nothing major going on. And I thought, okay, I've got some time to go to sleep now. And there were so many questions at 1:30 in the morning. I was answering more questions for people. And then finally I was like, okay, I need to go to bed now. So that's when I went to sleep. But I will tell you about
before you continue, I just want you to know, because I say that you put up a story.
Yeah.
So I'm super curious about, I wonder what he did. And then
you see 500.
I see 5 billion lines up here. I'm like, what did he do? And it's I'm like, oh, wow.
Yeah. And there's more
still on the way.
Yeah. I will tell you one highlight from my night of call. I can't give out any specifics, obviously, but I dealt with a patient that had something that was not known. No one knew about it beforehand. And this specific condition relates to a complication of delivery. And this patient very much had that complication of delivery. And for all those people that think it's safe to have babies at home and it should all be natural and kumbaya and let's all, yeah.
We're not dancing around this campfire, right?
No. For the first time in probably 20 years, at a split second, admittedly, it was only a split second, where even I was getting nervous.
Oh, wow.
It was that bad. Yeah. So for all those people that want to say, oh, the doctors are intervening and babies were born for millions of years fine and you don't need this. And there was one recent one, a doula, I actually managed to close her down, thank God, who said that it was insane that I thought that women should be considering an epidural. Not that they should have one. I say that they should consider it because I don't believe every woman should have an epidural, but they should have the right because it detaches the mom from the baby and from the experience. And like, yeah, if you were there to deal with what I was there to deal with, we're well past that discussion, right? Like this patient easily could have died if I had not done the things I did to prevent that from happening. And for people to think that obstetrics is all namby-pamby and, sit in the bathtub and just kind of chant the baby, yeah, it doesn't work that way every time. Sometimes it does. Hallelujah, great. I'm glad you had a good experience. But for the ones where it doesn't, like it goes from 0 to 100 like that. And if you're not ready, you're in trouble, like genuine, horrific, life-ending trouble. Yeah. So it was an interesting night for me. First time in 20 years, split second. I was like, am I headed in the wrong direction here?
Wow.
Yeah. Yeah.
Wow.
Scary.
Yeah.
Very scary.
You'll be tested. There'll be things you've seen that you haven't seen.
Yeah. And it worries me because there's this huge movement to like, stop listening to doctors and do everything natural and you don't need anything. And like, yeah, that doesn't work for everybody.
No. That's probably for the best case scenarios. Best case scenarios, people are just winging it. They're like, oh, even if they did nothing, it would have been all right. But how many people is that? What is the ratio of best case scenarios?
In obstetrics, stuff goes wrong all the time.
All the time, right?
Bleeding, infections, pulmonary embolism, amniotic fluid embolism, stuck baby, fetal heart rate decelerations, cord around the neck, asphyxia. I delivered one baby, had a true knot in the cord.
I just don't know why you would go through, let's say it's a normal duration of time, 9 months. 9 months to carry your baby, and the last minute you're like, well, you know what? I'm just going to take it a chance and what's the worst that can happen?
Yeah.
It's like, hello, a lot.
Yeah.
Like I would never. I never did.
I don't get it.
I never did. And I would never recommend. In my mind, it doesn't make any sense.
No.
Now let's say I'm in Antarctica. It's freezing, -500 outside. Okay, maybe.
Stay inside.
You know what I mean? If the doctor's willing to come into my igloo, okay, I'm good.
Yeah.
Otherwise, I'm going.
Yeah. I get it. I agree. I don't understand the whole, movement towards let's go back to the time when moms and babies died. Like, what's the benefit in that?
They forgot. So people forgot that medicine came so far ahead. So people don't acknowledge that. They're like, well, it's always been good. And it's like, no, man. It has not always been good.
Has not always been good. Yeah.
Because you actually did a video one time and you showed the graph of child mortality.
Yeah.
It was not always good. It is good now.
No.
But people ignore that they got the good rates via the fact that doctors did stuff.
We started intervening. That's how we reduced fetal maternal mortality.
Right.
And they're all like, no, you guys are intervening for money. Money. Especially my favorite's when they start saying you're doing it for money. Okay. The difference in Canada between doing a 2-second vaginal delivery where the kid literally flops out, you hand it to the patients, clamp the cord, pull out the placenta, you're all done. Okay. Like sometimes it's literally done in under 5 minutes, 5 minutes of work. Okay. The amount of money I get paid for that versus the amount of money I get paid for doing a placenta previa cesarean section with blood everywhere and all sorts of, risks and a little bit of panic and all that other stuff, right? $60.
That's the difference.
60 Canadian dollars, $60.
You're not even buying dinner at the Olive Garden. That difference.
$60. Like that's what you get. Yeah. Right. That's the difference for us. So like, trust me, I'm not doing it for money. Right. I'm not intervening for money. I'm not offering women an epidural for money because I don't get paid for anything related to an epidural. Right. I'm not offering women, oxytocin for the money. That's also $60. I don't really care about $60. It's not going to make me or break me. So, I don't get it. The whole movement is just this like psychotic push towards something that is medieval.
Yeah. Seems that way.
Yeah.
It seems that way.
Like, yeah.
Every time I read these comments, I'm losing my mind.
The same time,
I lose my mind on your behalf.
When people had the plague,
Yeah,
like that's what they're trying to take us back to. You don't believe in vaccines, you don't believe in medicine, you don't believe in intervention. Yeah, that's called like literally the plague.
Oh, you know,
let's get those giant masks with the beak. I'm going to show it. We should do that. You know,
let's use that again.
We should get one of those. Yeah.
A good way to work.
Hi, how are you? I'm Dr. Victory.
You should come in next time. This is what medicine used to look like.
Yeah. Yeah.
That's true.
Actually, those things probably made it worse because you probably just recirculated the same filthy air in the mask. 100%. Yeah.
Super gross.
Yeah. Looked cool, but I don't think it was good for you.
No, it was not. No way.
All right, let's go to some questions. What have we got?
Well, we're going to start off with a great one.
Okay.
This is fantastic. Right. Allow me to give it its proper due here.
Yeah.
The one and only Tariq. Great one.
Okay, now in defense of all the other literally millions of Tariqs out there, because it is a very common, first name
for me
for a Middle Easterner.
I'm willing to go with this.
He is the one and only Tariq for Fertility Factor Fiction.
Here we go, guys. Here we go.
Yeah.
I need some help over here.
Okay.
Well, let us help.
Let us help you.
We are here for you.
Yeah.
I'm currently priming with rapamycin.
Okay.
My cycle should start 3 to 5 days before my last dose.
Okay.
Can that be the cycle I start stims rather than waiting an entire month? If so, should I take my last dose a few days early, or can it overlap with that cycle starting stims? Or is it bad to take it close to or during stims if I have to wait a month? Will the effects wear off? And can the dose schedule I'm on delay my cycle?
Wow, that's a lot of questions.
A lot.
So I can always tell you that we use it for 8 weeks. We use it on a weekly basis, so 1 dose a week, because it has a better impact on the protein processing, which is how it works. So we would recommend using it for the full 8 weeks. I don't know what would happen if you used it for less, and quite frankly, I don't think anybody does. So I wouldn't do that.
We got a lot of love coming in here today.
All
My
right.
beloved physicians.
Oh, very
plural
cute.
on physicians, by the way.
Yeah. Oh, speaking of beloved physicians,
yes.
before I forget,
yeah,
Heather sent us brownies.
Oh, amazing!
Yeah. Well, she sent me brownies, but obviously
I'll take a bite.
Yeah, you could. But we need to make them. I got to put the icing on. But they arrived today.
Should have just brought it right.
Nice packaging.
We should just eat them right now.
Yeah. So Heather, I'm sure you're watching. I love you and baby brownie, and thank you for the brownies.
It's amazing. I completely got distracted with that because I haven't had sugar and
the Tariq's been fasting, so talking about brownies is good.
I'm happy about brownies.
Yeah.
So they're here today.
They're in my office.
Phenomenal.
Yeah,
this is a great
world-class brownies. Yeah,
world-class.
They are.
World-class.
They're the best I've ever had.
My beloved physicians, any update on IVM cases?
Yes.
Any more success than the 12-egg patient? How long until our turn? 88th on the list.
Oh, yeah. So we're aiming for getting through 20 a month. We're working on it. We're getting there. It's still building up a little bit. Retrievals are interesting. They're actually remarkably difficult to do. And that comes from a relatively lacking in the humility gene individual. So for me to admit that the retrievals are difficult is me, wanting to tear my own eyeballs out. But anyways, it is tough. It's really difficult. Now we're getting better and better each time. I think our yield is improving, but it's still not what I want it to be. I mean, when I go to get normal eggs, I'm getting every single egg. When you're doing IVM, you're only getting a fraction of the eggs you go for, no matter how hard you try. So it's getting better. As far as the maturation process, we're knocking that out of the park. As far as the egg quality that we're getting, we're doing really well with that. But what they're all turning into, it's actually still too early to tell. But we're trying to go from 1 a week to 2 a week to several a week so we can absorb the volume that is there. And we're trying to get to you.
Jumping on to TikTok.
I do think, can I just say,
yes,
before we jump, I do think it will be the future of IVF. I really do. I think we're going to stop pounding people with these expensive meds because I think we're going to get better egg quality doing it this way, because we are seeing very nice egg quality, even from women that shouldn't have good egg quality. So I think it's the future, but we're working on it. Yeah.
You ready?
I think I'm always kind of ready. I don't have a choice, right?
Okay,
You got to be ready. Yeah.
I'm ready.
Yeah.
5 failed medicated FETs with Orlissa. New doc says natural FET with new ER, no suppression or lap.
With new ER? Oh, with new egg retrieval, no suppression overlap.
Or lap.
Do they have endo?
No mention.
I mean, I can't tell you what to do, but I can tell you I don't practice that way. I would want to know why you failed 5 transfers. Is it your microbiome? Is it your immune system? Is it endo? Is it the shape of your uterus? Is it your partner's sperm? Was it the embryo quality, the egg quality? I don't tell people to do new IVF cycles when they failed 5 previous transfers. How does that help you? I haven't answered the problem, right? Like, your problem is you're failing transfers. Okay. Do we know why you're failing transfers? No. Is making more embryos the solution? How the hell is that the solution? Like, I haven't figured out what's wrong yet. This is the stuff that drives me crazy about being a fertility specialist, because we keep apologizing for what other people are doing. How does it make any sense whatsoever to tell someone that's failing embryo transfers to make more embryos so that they can fail? How does that make any sense? It doesn't make any rational sense at all. We're just, turning into like little puppet masters, and these poor patients are like, marionettes for us. Go do more IVF, dance around, more IVF, ultrasound, IVF, ultrasound, IVF. Like, it's ridiculous.
After the because we just did a little interview not too long ago, right? And I kind of felt, and feel free to correct me if I'm wrong here, but I kind of felt that there's this idea in the fertility world, not practiced by every doctor, but this is a bit of a disclaimer here on this comment here, but there's this idea. It seems that it's kind of like dentists, right? That, you have a cavity and the dentist will go and fill it. But for whatever reason, some doctors in the infertility world feel that you just need an entire new teeth. That's the feeling I'm getting when I'm hearing some of these things. Like, oh, you know what? You got a filling? No problem. New mouth.
It's true, right? That is true, or like going to get your car fixed, right? Like, I need an oil change. Well, actually, you need new tires, a new muffler. We do need to do an engine overhaul. Your seat scratched, changed all the leather. Like, it's insane, and you haven't even figured out what's wrong. I just need a freaking oil change. Like, fix my oil. It just makes no sense that they're doing this to people. It's hideous. Like, it's becoming. Look, I don't love all the negativity about doctors out there. Obviously, inherently, right? Me too. Me too. I don't like all this negative publicity that we're getting. I don't condone it or appreciate it. I don't love it. I think it's totally misplaced. I think it's unfair. At the same time, slowly, I don't think it has anything to do with vaccines and vitamin K. But when I see this kind of nonsense, I don't necessarily blame all the people that are saying
it's coming from a valid place. I
think the concern is legit. I think people are seeing something out there which doesn't fit the logic box, like, what is my problem? I don't know. So let's do something completely unnecessary, which is going to cost you thousands of dollars. And somehow that magically is going to make it better. No, it's not going to make it better. People aren't stupid. They know that, right? They obviously know that. And many of these patients are women, and they're like, intuitively, they know that, right? Like, they're great with that. And yet they're just having the, hood pulled over their heads. Like, they're not being told the truth or reality. And I feel like people deserve to be angry, and I feel like it's given us a well-deserved bad rap. I'm proud to be part of a select group of people that doesn't do that, but I'm ashamed to be part of the bigger group of people that is. It's getting bad. We need to change that.
That's what we're learning.
We need to change.
We're learning. Sure. It's a wild out there. It's a wild west out there.
It's ugly. Yeah.
Onto Instagram. Hi, Dr. Victory. How long before ER rapamycin and what dose should be used?
How long before ER rapamycin and what dose should be? Yeah. Oh, how long before the egg retrieval should you do rapamycin? We do 8 weeks. I can't tell you what you should do because you're not my patient, but we do 8 weeks. And what was the second part of that?
And what dose?
Again, I can't give out dose information because you're not my patient. I can tell you that people talk about doing 5 milligrams once a week. I can say that other people are doing different dosages. Some people are doing it daily. There is evidence that the weekly dose works better for the fertility world than it does for the other reasons for rapamycin use. So I don't think anyone's worked all these details out yet. So I can tell you what we would do for you if you are our patient, but shy of that, you got to talk to a doctor who's prescribing it for you.
On to TikTok, Dr. Victory. Hi, I am taking 2.5 milligrams of letrozole TID
3 times a day.
Before embryo transfer, age 43, due to hormonal drops. Chances? What are my chances?
I don't know. I have to know what kind of embryo you have. I've never heard of taking letrozole 3 times a day. I don't know why you'd be on such a high dose. We only use 5. We do them both at once. There's no reason to take it twice a day or 3 times a day. So that's a confusing protocol for me. Yeah. And you certainly can't take it up to your embryo transfer. You can only take it for a few days. It has to be out of your system, which takes about 5 days. Before you get to your embryo transfer, it's actually an abortifacient. It causes miscarriages. You can't take letrozole that closer. You're causing a miscarriage, not a success, a failure. Yeah.
Hello, doctors. Are BB and BA embryos ranging from 3 to 5 expansion day 5 and 6 good quality for 38-year-old?
Absolutely.
Dr. Victory, I'm 24 years old. I have stage 2 endo. AMH is 18.64 picomoles per liter. Chances of a natural pregnancy.
Oh, well, it's impossible for me to answer that. I need to know sperm quality. I need to know overall health. I need to know your BMI, your vitamin levels, your other hormones. I'd need to know how you came to that stage 2 diagnosis, how they did your surgery, if that was the case. So there's no way to answer those questions. But if you want to know if you have a chance, absolutely you have a chance. Do you have options that we can offer you to help you conceive naturally without needing surgery? Listen, let me be very clear about this. The surgery wait times are so bloody awful for people in Ontario or Canada, all overall for that matter, that I don't want you needing to go to the OR. Like, obviously we have to take some patients to the OR, but do I want you going to the OR? Absolutely not. So we are desperately trying to optimize things for people medically. And there are loads of things you can do. Medication protocols, supplement protocols, progesterone protocols, immune protocols, suppression. There are many, many different approaches that we can use together or alone to maximize your chances of success. Natural, IUI, or with IVF. Surgery is another option and a very, very good and important one, but not everybody needs IVF or surgery. Many people can try on their own. So do you have a chance? Yes. Is it a good chance? If you're only stage 2, it's probably a very decent chance.
Hi to my favorite Canadians.
Oh, there you go.
Do you offer lit therapy at your clinic?
We do, all day, every day.
Can an AMH of 0.5 be boosted, and what medication, supplements, or lifestyle changes will help?
Exercise, weight loss if you're struggling with your weight, healthy diet, DHEA, testosterone, human growth hormone, rapamycin, possibly Neupogen, yoga. Yeah.
Hi, doctors. What round of tests would you do after a failed 1-round IUI and 1-round IVF?
Oh. Well, I need to know what you mean by failed. Did you fail to make eggs? Did you fail to make embryos? Did you fail to implant the embryos? Were they tested for PGT? I mean, I need details on that before I can answer that. You can certainly DM me, but I need more information before I can tell you what I do.
Should you have a sonohystogram before you try for your second IVF baby?
1,000,000,000% yes. You could have developed polyps, fibroids, and isthmusal if you had a cesarean section scar defect. You could have had, inflammation develop. You could have developed adenomyosis or even endometriosis. So yes, of course you should.
Hello, Doc. What's your thoughts on IVF in Denmark?
I don't know anything about IVF in Denmark.
Well, there goes that.
Well, first of all, thanks for staying up till 2 or 3 in the morning to watch us from Denmark. I think that's kind of important to acknowledge. I don't know about Danish IVF. I can tell you that as a general rule, IVF in Europe is very, very inferior to IVF in North America. They are not getting our success rates or even close to our success rates. They're still using old technology, old protocols, old techniques, and they are not where we are in terms of success. Even in the more advanced countries like Spain, they're still not getting what we're getting. So I do think we're better, but I think that Europe is slowly catching up. A great example I've used many times. 2 years ago, I was in Valencia at a conference, mostly Europeans, a couple of Canadians and Americans, and they were talking about the FET protocol, and they were trying to convince the audience to stop doing medicated transfers. And so they said this should no longer be the case. It was a mistake to begin with. And we never should have done this. We should be moving on to doing natural cycles. So I went and spoke to the guy who was presenting, a wonderful German professor. The guy should be a supermodel, but he's actually an REI specialist. And I went to
Those
him.
Germans, eh?
Yeah, Geisinger. So I went and I spoke to him and I said, Professor, respectfully, I loved your talk. We need to move people away from medicated, but we need to actually get them on letrozole because letrozole is better than natural. And he said, we can't even get these people to move from medicated to natural. There's no way they're going to jump to letrozole. So that's how far behind Europe is. Like they're still stuck in 30, 40-year-old IVF. More power to them. They invented it, but we need to move forward from where they are. Yeah.
Hi, wonderful doctors. Canceled a fully medicated FET due to ovulating through meds. Estrase 4 milligram BID.
BID, twice
BID.
a day.
Mm-hmm.
That's just a statement?
Yeah.
Well, don't do a medicated cycle. Your estrase was way too high. And you can always take Cetrotide if your follicle's growing. There are ways to stop that. Also, why would you cancel? As long as your lining was thick enough, just start the progesterone at the right time and you're good to go. So I don't understand why they would have canceled you, but never do a medicated cycle. Highest chance of failure, lowest chance of success, highest chance of miscarriage.
Does a successful first transfer mean subsequent embryo transfers are more likely to work?
No.
Do you treat women or do you perform surgery for azoospermia?
Do I treat women? Yes. Do I perform surgery for azoospermia? We have it here, but I don't do it. I have a urologist come and do it.
Can my partner take something to improve his morphology and concentration?
Yeah. Vitamins, supplements, no drinking, no smoking, no drug use. Make sure you're ejaculating every day or every other day and keep the testicles cold. No cell phone in your pocket, no laptop on your lap, no hot tub, no sauna, no jacuzzi, no car seat heater, no sources of chemicals, sprays, anything like that. Eat super healthy, reduce weight. That's how you make it better.
Is it okay to take vitamin C and zinc while doing IVF stims, trying not to stay healthy?
Trying not to stay healthy, trying to stay healthy.
I'm assuming they must have meant.
Yeah, it's absolutely fine to do those. Yeah. In fact, most likely beneficial. One study I came across a few years back actually showed that your intrafollicular vitamin C concentration was a predictor of live birth. And it was right then when I told our naturopath to start giving people IV vitamins here. Mm-hmm. So we do administer IV vitamins. Yeah. It was because of that study.
Good afternoon.
Good afternoon.
46, one chemical, 5 fails of PGTA tested embryos. Last fail was after 2 months of Lupron and an immune protocol, Lovenox, 2 estrates 3 times a day, and 2 mils of progesterone a day. What could be the issue? I have regular cycles and a history of fibroids, but not in the canal, just the walls and outside.
Well, it depends on the size of the fibroids, depends if it's indenting. I need your microbiome. I need to know what your immune system is like. I need your BMI. I need the embryo quality. I need to know if they were PGT tested. There's a lot that goes into figuring that stuff out.
If I say I have a consult in June and we decide that IVF is about to go, there's a wait time at your clinic?
No, not for doing the IVF. There's a wait time to get in, but I will announce tonight, happily, that we now have a physician assistant with us who is sensational. She is smart as hell. She has learned everything I have to teach in a very short period of time. She is kind. She is sweet. She is lovely. She is really on top of everything. She's great at doing egg retrievals. She's getting better and better at doing embryo transfers. I freaking love her. So Stephanie Horvath is now with us. She'll actually be coming on the show soon, probably next week or the week after. And I love my Steph. She's amazing. And so we are going to be cutting our consultation time probably down to a month or 2 in the very near future, because she's going to be doing a lot of the consults. So we're very pleased, very honored, and excited to be introducing Stephanie to our team. So a big round of applause for Stephanie Horvath. Yeah. Yeah.
Are midwife hospital births safe?
Any birth in a hospital is probably going to be safe because we're there to back you up as long as there's an OB in-house. Midwives and doctors typically have the same overall goal in mind, which is safe mom, safe baby. How we get there is definitely different between the two of us. And so I think that midwives are probably generally more tolerant of patients wanting to push the limits on, going more natural, whereas we want to push the envelope of making sure that mom and baby are maximally safe. And those don't always parallel each other, like sometimes you're going in opposite directions. So is it safe? Yes, because we're there if there's a problem. If a midwife's in the hospital and something happens, they call us and we come running. We do have fetal bradycardias from midwives. We do have bad tears from midwives that we get called to repair. We have all sorts of stuff. So yeah, that happens. And we're available.
Thoughts on conventional versus ICSI when there's no male factor?
Yeah, this is a really good question. So if you look at the research on this, it says there's no benefit to doing ICSI if there is no male factor. But I will say that our team, especially lately too, I don't know what's changed, but God bless everyone in my lab, the ICSI success rates are just off the charts. So if I was only getting a 50, 60% fertilization rate, I would be saying there's no difference. But when your lab is not only getting very high fertilization, but they're also getting normal fertilization with ICSI, it's kind of hard not to want to tell people to do ICSI, because with conventional IVF in the best centers, you're going to get 50 to 60% that, get a good outcome. But when you're getting 70 to 80% or 100% with ICSI, like, why wouldn't you want those extra percentages? Those are more fertilized eggs. So that's my position on it.
Hi, snazzy gentlemen.
This is probably the least snazzy I get. You look good, but me,
you are always snazzy.
I don't look snazzy, but we're going to look snazzy this weekend because we're going to a gala.
Yeah. Look great.
My wife is going to look especially snazzy because I bought her a nice dress. Yeah. And ladies, I would love to hear feedback on this. Okay, here's a good one to bring up in this show. Okay.
Yeah.
I don't know how all the women out there feel about this, but I love taking my wife shopping to help her pick clothing. I actually thoroughly enjoy it. In fact, I'm the one that's running around the racks, finding stuff I know she'll like and saying, here, try this. So I'm very curious to know Am I like a weird anomaly, or do your husbands or partners or wives, I guess, like doing that with you?
I'm actually waiting for comments. I just want to see.
Yeah, because I love it. Like I absolutely love it. I love going shopping with her. And
isn't she the luckiest?
like it's awesome for me. I love seeing her look great. She gets that. Wendy has these beautiful green eyes, so she gets that sparkle in her eyes because she's happy. And for me, I'm like, I'm on cloud nine. My wife is happy. She looks smoking hot. Like, it's awesome for me.
She is lucky. My husband does the same thing with me. We love it that way. Yep, my husband is the same.
Oh,
I would
good.
love if my husband would do that.
I'm surprised to actually hear. Like,
love it. My husband helps me all the time too.
That's great. Because when I go shopping, the actual salespeople, they're like, "What are you doing?" And I'm like,
Dr.
"I do
V,
this
you
all
are
the time."
just the perfect man. Wendy is a lucky lady.
I am not in any shape, way, or form the perfect.
That is sweet and special. My husband hates them all, or even the idea of shopping, except if he needs to get his booze. There you go. The truth has been spoken.
There you go. All right. More questions.
Yes, you're weird. There are husband chairs for a reason. Sit and leave the shopping to the ladies.
Oh, wow. Really? Like a little hostility in there, eh? Wow.
I don't think I read it wrong. You know what I mean?
Yeah. No. I hate the husband chair. I never sit in the husband chair. I'm like, here, this will go with that. And I go find stuff on the rack and she loves it.
I think it's great.
As long as I'm paying, she's like, yeah bring more. Like, yeah.
Bring it all.
But I will say, when we first started this, okay, she refused to try anything. So we had to have like a heart to heart. And I said, no, we're not doing that. Okay. I know what you're going to look good in, because she doesn't like doing it herself. She wants me to go with her. So I said, I know what's going to look good on you and what you'll like. You have to promise to try it. You don't have to buy stuff if you don't like it. No problem. It's you got to do you, but you have to try it. If you don't like it, take it off. I'll take it back, but you at least have to try. And I'd say 80 to 90% of the time, the stuff I bring her, she ends up liking. So
that's great.
Yeah.
I'm jealous. My husband would just be at the corner and wait for me.
Oh God, no, I love it. Plus, if you're sitting in the right position, you get the little crack in the bedroom door, man. Like, that's fun for me.
What else can go? What else are you looking for? Yeah. No, we got them all. These are all the comments, I think.
All right.
I'm jealous.
Back to some questions.
Back to some questions. Yes, of course. You made me scroll all the way to the bottom, eh? So I apologize for those that I missed, because I'm sure I will miss some. But nonetheless, how do I miss this? Hello, handsome doctors. See, guys, there is a trick to it. People know it.
Yeah.
Warm wishes from Chicago. Just want to say thank you for all the education that you're providing us with. Looking forward to our consultation in July.
In July, no, don't worry, it'll be moved up. And by the way, Chicago, probably one of my favorite cities in the world. Thank you, Chicagoans. We love Chicago. 11 City Diner, best breakfast, one of the best breakfasts in the world. Phenomenal.
Is there any chance your waiting time to go less for an ET? Also want to add, you are the best RE. Thanks for the precious gift you got me in 2024.
Aw. There shouldn't be any wait time for an embryo transfer. So if you're just waiting for an embryo transfer, message your nurse and tell them you want to hustle. We don't make people wait very long, maximum like a month or two.
The glorious Dr. T.
The glorious Dr. T. I do give props to the people that like actually sit there and come up with new ideas for you. It's good skill. Yeah.
Great skill, great banter, great for the show, great all around.
Great everything. Yep.
Yeah.
Yep.
How much NAD plus subcutaneous injections do you recommend before stems? Also, thanks, Dr. V, for training Dr. T. That's a good one. See, that is very creative the whole way around here.
We use what most people recommend, which is 1,000. And if it's an infusion, we're still working it out. I've seen different things, so we're trying to figure out what the right protocol is. We're trying to get our infusion set up. We are actually currently lacking in space. So we're working on that.
Hello, Dr. T and Dr. V.
I love it.
I love it. My age is 32. I had 2 losses. My cycle day 3 FSH has always been 12 or 13. AMH is 20 picomoles per liter. Does this high FSH matter?
Her AMH is 20 picomoles per liter?
Mm-hmm.
No, your FSH is irrelevant. Your AMH is a much more sensitive test. I don't know why your FSH is so high, though. That wouldn't make sense. I'd need to meet you and figure out if there's some sort of endocrinologic abnormality here.
My ER was yesterday. Can I do Lupron Depot in a couple days on cycle day 21 and do an FET next month? My nurse thought you wouldn't let me do Lupron Depot this soon, but I'm also not sure if I need it.
You could. It's a bit of a rush. I'm not sure you're going to like the side effect, which is that the first week causes a flare and it could cause the eggs that are there to grow bigger. So that might not feel great and it could mess up your hormones. We usually wait a month. There's no like super rush. 1 extra month is not going to make or break you, but it will probably improve your chances if you wait.
Having my virtual consultation with you this Saturday.
Oh, awesome. Right before the gala.
Right before the gala.
I hope they left me enough time to go home and change. Yeah.
If someone came to you at the age of 36,
okay,
trying to conceive, already 6 or 12 months by the time of the appointment, what is the first thing you would test for?
First thing I would do
is I've already had 1 healthy pregnancy.
First thing I would do is have a chat, learn everything about you, all the details, and your partner. Then I would test your partner, hormones, cholesterol, metabolics, blood type, infectious disease screen, semen analysis. And then I would test you, hormones at a minimum, vitamins at a minimum, metabolics, again, at a minimum, blood type, that kind of thing, infectious disease screen, saline infusion sonohistogram of your uterus and ovaries and tubes, and ideally kind of map out what your cycle looks like, but at a minimum, the SIS. So those are the things we would do. We don't do just 1 test. 1 test is useless. Tariq and I just did a podcast. We spoke with Illyriana from Healthily on Instagram. Very, very interesting young woman with a really compelling story in her fertility journey. And she said that she went to a Florida-based fertility clinic. We're not going to mention names. In fact, she didn't, so I can't. But in any event, she went there and they told her she was 32 and that she probably had diminished ovarian reserve. She did, and her ovaries are very strong, very, very strong. And then they told her that it didn't matter because she wanted 2 or 3 kids, so she should hurry because she didn't have time, which makes no sense when you have a high AMH. And then they did 1 ultrasound, and she said they took her to the finance office. And then the guy started saying, this is what you have to pay for IVF. This is maniacal. That's not the way it should be. So we want to do better than that, for sure. So, you have options, you have choices. There's different things that people can look at. We don't start with just 1 test. We actually look at what's wrong. We figure out what's wrong. And based on what's wrong, we give you all your options.
Can endometritis be caused by prolonged labor, scalp fetal monitoring, and OB needing to turn baby internally during delivery?
Can prolonged labor do that?
No. Can endometritis be the cause of miscarriage as well? So they had 2 questions about endometritis.
Okay, wait. Ask that question again.
Okay. I'll even do an introduction. Dear Dr. Victory.
Dear Dr. Victory. Okay.
Can endometritis be caused by prolonged labor, scalp fetal monitoring, and OB needing to turn baby internally during delivery? Can endometritis be a cause of miscarriage?
Yes, and yes, absolutely. The longer your labor, the more time and opportunity bad bacterial colonies from the vagina can go up and colonize in the uterus. The more times we examine you, the higher the rates of infection. The more that there are instrumentations examinations, ruptured membranes, all of that stuff, the higher the risk of infection. So that's absolutely the case. There's no question whatsoever.
Any testing you'd add to a typical workup with a history of 10 years of secondary infertility without pregnancy, stage 3 endo excision in 2024?
Microbiome, immune, sperm DNA fragmentation, vitamins, shape of your uterus, metabolics, all sorts of things we'd look at. Meioxis testing for the sperm, hyaluronic acid binding testing for the sperm. I mean, we got loads of stuff we could check out. Basic fertility testing is going to get you really basic results, right? Like if you want to be a good fertility specialist, you don't just have to be able to even offer the test. You need to know what tests are available. Then you need to know how to apply them. Then you need to know how to interpret them. I think one of the reasons we do really well for our patients is because I force myself to learn all that stuff. And when something new comes out, I learn that too. So that's how we work.
I'll do something. 41.
Yeah.
4 euploids.
Yeah.
Plus receptiva score 3.0. Suspected endo and adeno. No lap as only SNS is painful, period, and infertility. Lupron Depot 60 versus 90 days suppression before an FET. Fully med or modified natural FET.
So Lupron Depot prior to an FET is proven useless. Unless you're combining it with letrozole, it's proven useless. So I don't advocate for that for sure. 60 versus 90, there's no comparison between the two. So I can't scientifically provide you an answer. There is one study that did 30, 60 and one that did 90. So they both showed a benefit, but I can't tell you if one's better than the other. We kind of judge it based on the severity of the disease. And both of those are not sufficient for endo-adeno, in my opinion, because you need an entire protocol that addresses the immune function, the natural supplements that you need, the lowering of the inflammation, the suppression of the endo and the adeno, and the progesterone requirements.
Comment on TikTok that just came in. I think it's a fresh question. You're taking questions?
That's literally what the show is. We take questions.
Maybe
newbie.
Yeah. They don't know. They didn't know Dr. Victory actually takes questions.
You know what? We'll do a midway introduction to the show again. This is Fertility Factor Fiction. I'm Dr. Rahi Victory, my best friend here, Tariq Ibrahim from Ibrahim Strategies Group, and we literally answer fertility questions live. You can ask us anything. Generally speaking, we're prepared to answer. Do you know that your watch is woefully off on time? I just realized that.
All of Ramadan is off. I'm just completely off.
All right.
Time is the least of my problems.
Yeah.
Do you recommend tube repair or removal for hydrosalpinx for an IVF?
Look, I do tubal repair surgeries. I would tell you that the vast majority of them, if it's got a hydrosalpinx, don't work very well. So can I do it? Sure. Am I good at it? Quite frankly, I'm excellent at it. Does it make sense? The vast majority of the time, no. No matter how good your doctor is, you're never going to restore tubal function. And then if you regain your hydrosalpinx, now we got to go back in you again, which sucks. So if you're already doing IVF, why would we leave the tube? I guess would be my question. Doesn't make sense to me.
I said I missed a question before the snazzy doctors. I feel like I didn't. No, I asked it. So 5,000 versus 10,000 units of HCG. Did we ask that?
Oh, dear God.
Did we ask that?
No.
No.
No one should be getting that much HCG.
Anyways, hi, snazzy gentlemen. In poor responders, how do you decide between 5,000 versus 10,000 units of HCG in a dual trigger with triptorelin? Do you believe higher HCG doses improves maturity rates in DOR patients?
Yes. So in a DOR patient, we give you a full dose. In a non-DOR patient, for the love of God, don't do that. I just had a patient that took the wrong dose of HCG, and for the first time in years, ended up with hyperstimulation syndrome because we specifically told her to take 1/20th the dose she did. and she didn't. So yeah, that was problematic.
Dr. Victory,
Yeah.
somebody watched our video. If
Okay.
the egg chooses,
Yeah.
why do ICSI?
Oh, yeah, that's a great question. You still get a higher success rate. Some of these eggs are too picky and they kick off all the sperm.
Oh, really?
They're like my daughter. No one's good enough.
That's great.
No one's good enough. Yeah.
Hi, heroes.
Like Wendy's cat. No one but Wendy.
No one but Wendy.
Yeah. Yeah.
When do you use an HCG wash, and what type of patients do you think benefits?
We use an HCG wash typically after someone's failed the previous cycle, although you can use it on a first try. The studies show it's up to a 30% increase in live birth. So I think it makes a lot of sense. It's very easy to do. It's not expensive. So we do it 15 minutes before. That's what the meta-analysis showed. Granted, it was an Iranian meta-analysis, but the studies weren't all Iranian. So I support what they said.
There you go.
And that's coming from an Iranian.
There you go. Hello, beloved doctors.
Yeah.
Any advice for enduring Lupron?
No. It sucks. I tell women all the time that our endo protocol is, phenomenal. It works so well. So many success stories after so many failures. But you know what? It sucks. Like, it's just horrible. It's a very not nice thing to do to a lady. So yoga, meditation, healthy diet, go target shooting. You can put my face on the back of the target or something.
Whatever gets you through it.
Whatever gets you through it. Yeah. And I'm sorry for doing it to you, but no. People are like, oh, my doctor said I'll take Lupron with norethindrone. You can't do that. There's no evidence that that's suppressive. So we don't do that.
AMH 0.84.
Nanograms or picomoles?
No mention.
Okay. Guys, when you're giving me a measurement, I need the units, because remember, the US and Canada are different.
I don't get to embryo stage. Did 2 IVFs. What can I do to get the embryos?
I need to know at what stage in your IVF embryo development it fails to develop. So, for example, I had someone reach out to me on Instagram. She consistently gets to day 3 and then it conks out after day 3. And that's a sperm problem. That's not a female problem. So I need to know, is it happening earlier, later? What's the problem? Are they arresting? Are they turning into bad quality embryos? I need more information. You're making funny faces, which always means something funny is going on in the background. So what's happening?
Heather is checking in on it.
Oh,
on me.
okay.
I think she's checking in on me. I'm
All
going
right.
to say,
yeah.
Hope you guys had brownies for dessert tonight.
Yeah.
And we did not have brownies for dessert.
No. But I announced that Heather, I announced that you sent us brownies, and I promised Tariq I would give him a very small piece.
No. From what I'm reading,
like very small.
it sounds like, did you have the brownies for dessert? She's asking again.
No. Just like very small. Very small. Tariq says he doesn't need that much. Too much weight recently.
That's also true. But I would never allocate that weight to a brownie problem.
Yeah.
There's other foods that I should avoid.
There's only so much love we have for each other, man. The
brownies is where it ends, eh?
Brownies, yeah. I'm willing to share with you. I literally didn't give anybody else in the whole clinic any of them because I saved a bit for you, and the rest, they're going home. Will I polish them all off? Yes.
Day 731 of asking for a recipe to share for the brownies.
It's Heather's secret. I do have the recipe, but you know what? They're so freaking good. I wouldn't even try it myself because it would just ruin the whole experience.
Ruin the whole experience. 1000%.
Yeah. And for those of you that are not aware, Heather and I call her baby brownie. Yeah. Legendary world-class brownie. So good.
Hey, Dr. V and Dr. T. Actually, doesn't say Dr. T, just says T. I'm skipping the question. No, just joking. Coming in 2 weeks to start the IVF.
Yeah.
What is the general timeline for IVF process? Try to be patient. We have been trying to have a baby around 3 years, male and female factor infertility.
Sure. Takes about 10 to 12 days to stem on average, 5 to 6 days to make your embryos. And then we wait 1 or 2 months and we do your embryo transfer.
I'm not going to lie.
Yeah.
The brownie thing is dead in my head at this point. It's as if I haven't eaten all day.
They're very, very good.
Hi, doctors. Thoughts on low-dose naltrexone to help conceive?
Absolutely no evidence anywhere in existence showing that low-dose naltrexone is beneficial for fertility patients.
New word of the day. What is your opinion on using cabergoline medication to treat endometriosis?
I'm not aware of any evidence that suggests that cabergoline is good for endometriosis. We use it for hyperprolactinemia. I've never seen that before. I will look that up for you guys with the few minutes that remain. However, I will say, and this is important, that the majority of the evidence these days is in regards to GLP-1s. People are really pushing hard on the idea that Ozempic, Saxenda, Wegovy, all that stuff is what's actually going to be really beneficial for endo patients. Very, very interesting. Is there any evidence for the use?
Is that from a medication perspective, or is it a weight loss benefit?
No, reduction in inflammation.
You
do reduce your inflammation. Yeah, like I snore less when I'm taking Wegovy.
Instantly?
No,
like you take anything, or it's because of the loss of weight?
Yeah, I'm down again like 13 pounds.
You're invisible at this point. I can't even see you.
For endometriosis. All right, let's see what it says. I'll tell you. Ask another question.
Hey, Dr. Vinti, coming in. Oh, we did this one.
Oh,
go.
Yeah,
you got it.
Go.
Can I get pregnant with a probable hydrosalpinx due to chlamydia, but doc never sees liquid in scans? I have had a hysterosalpingography and looked blocked, but not seen any scars. From Spain.
Well, hello from middle of the night Spain. That's 4 a.m. in Spain.
11 Spain.
No, 3 a.m. in Spain. Wow. Hi,
we were
Spain.
talking about that today, right?
Yeah. 2 a.m.
Yeah.
2 a.m. in Spain. 3 a.m. It's almost 3 a.m. Yeah. So hello, Spain. Hola. ¿Cómo está? And yeah, I would probably say it's going to be very difficult to get pregnant with a hydrosalpinx. If you have damage to the fallopian tube, it's probably dysfunctional, and that's going to make it much harder for you to be successful, for sure. Okay, let me read this real quick. So 50% of studies that were evaluated said, yes, cabergoline could be effective for endometriosis. 38% said possibly, 13% said maybe, and like yes and no, and no studies said no. Their overall summary: overall, cabergoline has consistent mechanistic and early clinical evidence for reducing pain and, to a lesser degree, lesion size in endometriosis while preserving cycles. However, trials are small and short-term. It remains an off-label emerging therapy best considered in specialist care. That would be me, especially for patients wanting non-hormonal or fertility preserving options. Look at that. We learned something new tonight. I did not know that cabergoline was available. Here's the problem with cabergoline. Every single patient that takes it feels like they want to puke. It's not stomach friendly. Yeah. Makes you really queasy.
Interesting.
9 o'clock. One more question.
Well, and then on this, can I get to see you based off of your website, or do I need a referral?
Well, if you're in Ontario, you want to do it through a referral because then it's free. If you're not in Ontario, sign up through the website.
There you go.
There you go. Listen, everybody, it's been a slice. Thank you for joining us on Fertility Factor Fiction. Myself, Dr. Rahi Victory, and my co-host, Dr. in quotation marks, as always, Tariq Ibrahim. And we're going to go have some brownies. Have a good night, everybody. We'll see you next week.
Somebody said I got distracted from the brownies and I therefore didn't answer a bunch of questions. I'd just like to clarify and say this time ran out, guys.
Have a good night, guys. We'll see you next week. Fertility Factor Fiction.